to feeling on echocardiography if the valve is still in the intended location. But to accurately define whether it's displaced or dislocated 1 millimeter or if there's been a change in angulation, I haven't seen any of that type of data.
Okay, Nick, thank you very much. I think these patients are being followed up in such detail that will become apparent if there is either movement in an aortic or ventricular direction. I did have a long introduction for Peter, but given time, I think welcome to our Secretary General and congratulations on the meeting, and as always look forward to hear what you have to say.
Thank you very much, Neil and Mirko. And I'm glad there's still a lot of people here in the room, because we need some kind of discussion about this subject. And I will go through the first slides quite quickly because we run short on time. And then we hopefully will come to this discussion. The question is it now time for a randomized trial? And I think that after the presentation from Niccolò Piazza, it is even more apparent so that the durability will play a role, and how do we find out? And the only way to do that, especially if the patient characteristics differ now from surgical valve literature and percutaneous valve literature, the only way then to find out is to do a randomized trial. Because there are questions. What is now the aim of actually transcatheter valve implantation? It should be less invasive, but at least we want to be as effective as the surgical valve implantation. And then hopefully with less morbidity and with perhaps even less mortality. So at the moment, TAVI is still reserved for high-risk inoperable patients, but that will change. Of course, with more experience, and especially we also shift a little bit towards the cardiologist, and they are the gatekeepers in many instances. They may shift also to lower-risk patients. So the following question remains then, is there less morbidity associated? Is there less mortality associated with it compared to conventional surgeries? And is it really addressing a need for high-risk patients? So we just looked very briefly, I will talk about this study, where we looked at the surgical valve implantation and the percutaneous valve implantation from Rotterdam and from Bern. So two different centers, all with core valve patients implanted. 500 patients were excluded from this study, from the surgical patients, and 1,120 patients, 22 patients were included in the study. We had 114 in the TAVI group, and we had more than 1,000 patients in the SAVR group. So 114 transcatheter valve patients, more than 1,000 surgical valve patients. Now, if we look now at the outcome, of course, then you have to keep in mind these patients are not randomized. They are just observations here. But there are, of course, differences in baseline characteristics. The one with a transcatheter valve implantation will be sicker, and the surgical valve patients will be healthier. So we need risk adjustment techniques. We need statistical tools, some people will say tricks, to try to adjust. Now you have a number of statistical tools that we can use nowadays. Here there are 4, and there are another 3 here, and then we have an IPT-weighted multivariable analysis adjusted for all baseline characteristics. So if you want to look it up, there's a reference to this, and you dive into the statistical literature. So, but of course, nowadays the epidemiologists and statisticians and the computers, of course, are very helpful in this. So here we have the TAVI population, 114 patients, more than 1,000 surgical patients. And you see, of course, age differs very much, 83 in the transcatheter patients and only 70 years in the surgical patient population. And of course, the logistic Euro score differs, 20 here in the transcatheter group, 9 in the surgical group. And of course, there are other more striking differences. For example, more patients with a previous CABG in the transcatheter group. Now, I want to go over this quite quickly because we will know that these baseline characteristics, of course, differ. And again, many differences. The transcatheter patients are much sicker than the surgical patients. Distribution of age. If we look here at the surgical patients, this is the distribution of age. And you see most of them are in this range here, 65 to 80. And the transcatheter patients are much older. Now, if we look at the logistic Euro score, you see that the surgical patients have the lower scores, and you see the transcatheter patients have low scores and very high scores, up into a logistic Euro score of 80. So it's actually very difficult to compare these. And so if you do a propensity matching, you see the distributions of the propensity scores, surgical patients from 0.9 to 1, and a scatter here of patients along the x-axis with transcatheter valve implantation. So how much overlap is there, and can we really propensity match these patients? Well, that will go to be very difficult. So this is the mortality outcome, 9.6% in transcatheter valves and 2.3% in surgical valve patients. So now what are the significant predictors if we try to do this statistical analysis? Univariate, age is of course important. The older you are, the more likely you will die. Well, that's something we know for a long time. Of course, Euroscore is important. New York Heart Association class is important. Diabetes is important. Atrial fibrillation, creatinine above 200, and whether they had a myocardial infarction within 90 days. So now we look at the multivariate analysis. Logistic Euroscore, of course, is important. Something we could expect, and atrial fibrillation. And most probably this is a kind of confounder or a proxy for some other variables. Now we do this risk adjustment. Look here, all these different tests that we use to try to adjust for baseline characteristics. And actually it's quite difficult. And you see that here it shows that TAVI is more beneficial, and all these other tests suggest that the surgical valve implantation in patients is more beneficial. Well, actually you can conclude everything. Adjusted odds ratios for 30-day mortality range from 0.6, so it means then that it's better, to 7.57 mean that it's worse because it's above 1. So no conclusion actually to be made from this propensity match study because the propensity matching fails here. There are many confounding factors. So this is actually a little bit the basis then why I say, well, we have to come to a randomized trial. Because now to compare surgical valve patients with percutaneous valve patients is actually impossible. Goals are now to define the patient to be treated with TAVI and to define the patient that are better off with surgical valve implantation. And I think it should be a kind of all-comer study. No highly selected patient population. And it should be the heart team that decides which patients should get a percutaneous valve implantation and which one a surgical valve implantation. And at the same time, we will have nested registries. So at the same time that we say we can randomize a certain portion of the population, at the same time we also want to define, well, which were the patients that we have sent to surgery and which one definitely need a percutaneous valve implantation. So the heart team discussion is crucial here. But it allows for flexibility because Thomas may say, well, you know, I have a lot of experience with transapical implantation, and in these kind of patients, that's a safe procedure in my hands. Well, in our center, they may say, well, you know, I have a little bit more difficulty with doing this, and they may say, well, this patient should be sent for surgery. And when there's doubt whether surgery is the best option, then you can randomize. So the heart team discussion is crucial. The surgeon may say, I cannot do it, or I don't want to do it because I know this patient has a porcelain aorta, and the patient goes for percutaneous valve implantation into a TAVI registry. Or a surgeon says to the interventionalist, you should not do this because I know that surgery has a very good result in this patient population. And so this patient should undergo surgery. And he goes to a surgical registry. And then in the high-risk patient population, or in a high-risk patient, the surgeon may say, well, I can do this, but it's risky. I can operate this patient, but maybe transcatheter valve implantation is a good option in this patient population. And so then we can randomize. So when in doubt, let's randomize. It looks a little bit like this kind of looks a little bit like the Syntax trial. You know, there was also a heart team discussion. Patients could be randomized or patient went to a registry. So now I'd like to have a little bit of your opinion. So I see if this is going to work. Do you think it's time to randomize patients for transcatheter implantation?
Yes, I think, because there have been numerous cases have been done, so I think it's time to do it.
It's time to do that? Are there opinions here? Industry? Jean-Paul?
There's already one trial in process right now in the US, right?
Yep.
So we should get the result quite soon.
Yeah. But do you think now that we have this heart team discussion, so instead of just taking high-risk patient where we say, well, you know, we can also then lower, for example, the age, or we can go to lower risk patients, because it allows for that flexibility. Do you think that's time for it, or?
There's a lot of other additional data we can find from the source registry right now, which I'm sure we can, favor some other, aspect to that.
Okay. Olaf, what do you think?
Well, I think the data you have shown shows that there is a lot of more data available, and I would not go in the source direction at the moment. I mean, that's something available as well. But I think there is the nice difference between the two devices which have been used is that two different patient groups have been treated in a way that, as you showed, that's a core valve collective, and you have a mean US score of 20. The nice thing about the mean US score of 20 is if you have conventional operated series of octogenarians, you usually end up with a US score of something like 16 or 17. And instead of comparing it to a group of patients isolated aortic valve replacement, I would compare them directly to octogenarians. And for example, if you have in mind the work from Thomas's from Leipzig and the octogenarians, that was again a mean US score of 16. The nice thing about the core valve collective is that the US score actually matches quite nicely to this octogenarian group with conventional surgery, and therefore I think one should directly compare the outcomes of the core valve with this group, because I believe the demographics of these two groups are much more similar. The big problem we have with the Edwards procedure is that, or with the Edwards cohort, is that the Edwards US score is 25 to 29, or 25 in TF and 29 in Transcatheter, and that's the reason why you never, or you always have more problems to find a conventional operated cohort as a comparison. But I think that would be an interesting point to look at first before you go to the next randomized trial. I think we need to have in mind one randomization is done against transfemoral. Conventional surgery against transfemoral. The trial is inclusion is stopped. We will have the data by next year, October. I think the next randomized trial would be, from my point of view, TA versus TF.
Okay. So no randomized trial for Olaf, only TA versus TF. Other people with Giuseppe?
I think we should wait till the technology is improved, because I'm afraid that what's happening with the syntax is going to happen with that. Somebody's going to stand up and say, hey, there's a better stent now, we need to do another randomized trial. I mean, stents have been around for a long time. Percutaneous valve have been around just for a few years, and I'm sure that like in a year, there's going to be another better valve. And then what are we going to do, another randomized trial?
Yes? I think so. What do you think?
I agree with the latest speaker that the problem is the fast technology here, but I still think we need a randomized study in high-risk patients.
Other opinions here? Yeah.
I think we need a study of all of the patients who are getting those transcatheter heart valves. I mean, as we have had examples in the last 2 days where they also put these transcatheter valves in 50 or 60-year-old patients with low risk, and I want to see the long-term results of those.
Yeah. Well, I think also the best way, if now you see patients like 50, 60-year-old who gets these valves, to really find it out, you have to do a randomized trial. And it's the doctors who then decide which patients should be randomized. Of course, you may question yourself, and I think that where the technique is already so far advanced that we say, well, this type of valve will stay now on the market for at least, let's say, 3-4 years. And of course they will change. And of course that's progression of medicine. So the danger is there a little bit. If you wait, there will be another generation, but people will start using them. And that is something we have seen in Syntax also, that you can say, well, we don't want to randomize because they will come up with a biodegradable stent, but still now people treat patients with left main disease with stents. So as surgeons we can sit back and say they're stupid, but it's daily practice already. And the same for percutaneous valve. So in Syntax, it's the interventional cardiologist says, I can do it or I cannot do it. And the interventional cardiologist is faced with a challenge to treat and randomize higher risk patients. So we as surgeons are quite comfortable to treat high risk patients in coronary surgery. Extensive coronary disease is not a big deal for the surgeon. So the cardiologist says, well, I can open this chronic total occlusion or this very calcified vessel, yes or no. In Syntavi, in the Syntax-like transcatheter valve trial, it will be the cardiac surgeon says, I can do it or I cannot do it. Because it is a too high risk patient, calcified aorta, and he's 86 years old. And so then we are faced with a challenge to treat and randomize high-risk patients. So we say, well, there's an 86-year-old calcified porcelain aorta, but still I think I can treat him with surgery. Well, then we face these high-risk patients and a kind of challenge to treat them as good as with percutaneous heart valves. So the heart team should also have some risk scoring and also try to come up perhaps with a new risk score. The surgical registry will contain patients with low risk because here, like a 60-year-old, where we know the outcome is very good, it's about 0.5% perhaps hospital mortality and a long-term durability of the valves. So we will say these patients should definitely have surgery. And then there will be a TAVI registry of the inoperable patients, whatever we call it, but inoperable patients, patients that we don't want to treat. And then we can randomize patients where the heart team thinks that this could be a patient that is better off with percutaneous heart valve or with surgery, and there's doubts, and so we should randomize these. So now how to design this? If the patient is inoperable, we have to decide what is inoperability and who decides inoperability. The control group should be optimal medical therapy or balloon valvuloplasty. Endpoints should be mortality and a secondary endpoint at 5 years. Trial design should be a randomized trial. Statistical analysis should be superiority for efficacy, so it should show to be superior than medical treatment, and non-inferior for safety, so it should be not worse in terms of safety compared to medical therapy. Now then we have these patients that can be operated, so actually the group that we're talking about. Inclusion could be regular operative patients, control group, surgery. Endpoints, mortality of course very important, the valve function at 2 years, and secondary endpoints should be at 5 years. Because I don't believe, if we just see one patient who's doing fine after 7 years, we have to see a lot of patients doing fine at 5 years or 7 years. Trial design randomized, non-inferiority for efficacy, so it should be as good actually as surgery in terms of valve durability, and it should be superior because we have a new kind of treatment and we hope that it will be safer. We hope that patients can be dismissed earlier, lower mortality and lower morbidity. So now we had a VARC meeting. We tried to come up with definitions for trials, but already you see what is mortality. Is it cardiac mortality? Is it all-cause mortality? Is it early mortality? Etc. Morbidity should be defined for these trials. And then bleeding events should be defined. And if you now look at cohort studies of transcatheter valves, you see many, many different endpoints, also in terms of mortality. So, and then the other one is valve endocarditis, what we have to look at. We have to describe the patient population, the method of follow-up, the follow-up time, the bleeding events, and the valve outcome versus patient outcome. So I go over that quite quickly. What we see now is that PCR with surgery with an on-site with PCR with a surgery on site, is there we had the heart team discussion. And these centers, they stick to the CE mark labeling. So this is what you could say the university centers in Europe. They have surgery, they have PCI, and they discuss whether the patient should be treated with transcatheter valves. But now we also have PCI centers that do not have surgery on site. And there you will see the broadening of the indication. So less sick patients and younger patients will be treated. And then we have centers with PCI without surgery on site. So these are centers that PCI is there, but they don't communicate with the surgeon. And you have centers where PCI, but there's no surgery at all on site. So there we have the self-referral process. The patient comes in and said, well, you have an aortic stenosis. And then the patient says, well, doctor, how do you treat this? Well, I said, I can do that now with a stick in the groin, with a small puncture in the groin, and I can put this valve in. No, you don't have to go to another center where they have surgery. I can do it myself. And so here you will see that they will treat younger patients with less comorbidities who are actually good surgical candidates. So that is why I think it's important to start a randomized trial, because otherwise this will happen, and it is already happening. So 39% of the centers